There we are.
Good.
We in?
Hi there, Michael.
Hi, how are you doing? We finally got there.
Yeah, well done. Nice to see you.
Thanks. Same to you. Same to everybody.
So, Michael, the idea about this is it's going to be a panel discussion.
Yeah.
Looking at the problems of restarting surgery, what problems people have had, how they've got around them, and to have a general discussion, really. There's going to be, I think, 5 of us, 6 of us on the screen. So when you want to speak, if you want to make a comment, just indicate by putting a finger up or a hand up so I can see.
Okay. All right.
So I can bring you in to the
All right.
discussion.
Hi, good evening, everybody. It's just 6 o'clock. We've got participants joining, 75 people online at the moment. So I'm just going to give it another moment, if that's okay, to let a few more join, and then I'll go through a welcome and housekeeping and hand over to Professor Spalton for tonight.
So Jill, I can't see the other panelists on the screen. Should I be able to?
Yeah, go to gallery view, David.
Can you see me?
I can, yes, okay, yeah.
Perfect.
You can see Michael, you've got the most important person anyway, so.
Of course.
I want to get the whole, hang on, I want to make it full screen though. Jill, how do I make it full screen? Is that, here we are, I've got Michael O'Keefe on, but I can't.
So at the top, you've got a grid. You've got 1 block, 2 blocks, or 9 blocks. If you do 9, you should be able to see everybody.
I've just got 6 on that now, not 9. Where's that? How do I get 6? I've got.
David, you won't get all 9 now because you're sharing your screen, aren't you?
No, I'm sharing a screen.
Or somebody's sharing a screen, so then you end up with a smaller number on the side.
I see. So when we stop screen sharing, do we go back to getting everyone on?
Correct.
Yeah.
Yeah.
Just make sure on your top right you have pressed the gallery view, David.
So I would tell me again, Satish.
On your top right on your screen, make sure you have pressed. There is speaker view and there is gallery view. If you press gallery view, then once Jill stops sharing her screen, then you will be able to see all of us together.
Okay, so we've got just under 100 participants live on the webinar at the moment. So just going to give it another moment and then I'll do a quick welcome. David, may I ask you a question, please?
Yes, certainly.
would you like, so we're going to keep all of the panelists off mute and on camera throughout because it's going to, yes, conversation. Perfect.
Keep everyone off mute so people can come in as they want to.
Okay, so we've just got over 100 panelists. It's 6:03, so I'll just make a quick hello. Welcome to everybody once again who's joined the series of Eucharistus webinars. This one this evening, supported by Daybreak Medical, Ted Goodwin and team. We're very grateful to you all. Thank you so much. The webinar tonight is problem solving in the new normal, and David Spalton will tell you a little bit more about it in a moment. I'd just like to go through the format of the evening. For CPD is now self-referral, so if you would like a CPD certificate, then please complete the evaluation that will be sent to you directly at the end of this call. The evaluation link will come via Zoom to you at the end of this call. For Q&A, we have our moderator, Mr. Sarge Khan. It's a different format this evening. We're not waiting till the end to ask questions. We're going to ask questions as they come in, conversational style. So if you have any questions as you're hearing comments, or you'd like to make a comment yourself, then please use the Q&A function and Sarge will pick that up for you and ask the questions to the panelists and to David. The webinars are usually around an hour long. We do sometimes overrun dependent on questions and how conversational indeed that we are. So I'm going to sign off now. As I say, thank you to all the panelists, and I would like to introduce you and welcome you to Professor David Spalton. Thank you, David.
Jill, thank you very much. Let's see if we can get onto the full screen. Jill, yes, that's good, thank you. Let me just. Just one moment. I'm just trying to get everyone on the screen. Okay, Jill, I'm having problems seeing everybody on the screen at the moment. What's happened?
Okay, so I'm just trying to imagine what you're looking at.
I've got, I can see Michael O'Keefe, but I can't get the, what have I got to?
In the top right of your screen, and if you hover over, have you got gallery view and enter full screen?
Enter full, I've got to enter full screen
So
now.
to the left of that, do you have gallery view?
Yeah.
If you click that, you'll be able to see everybody.
And we're there. Thank you very much. Okay, Jill. Well, thank you very much and welcome everybody. This is the idea of this evening is to look at the way people are restarting their surgery, the sort of problems they've had. And we're very fortunate really to have around Britain sort of panel this evening. I'd like to introduce Satish Srinivasan from Scotland. Satish is going to be the next president of ESCRS. Then we have Beta Mansouri from Romford in London. The background there is not typical Romford, but it looks very nice. Michael O'Keefe from Dublin, of course. Judy Silvestri from Belfast. Sarge is going to be answering the questions. And
David, I'm going to be asking the questions, not answering them.
Answering the questions, okay. And there we are. We got, yes, someone, Scotland, and Vinod Kumar is going to be joining from Wales, from Cardiff, in I think a moment or two. So we're waiting for him. So I'm going to start off. Have you all actually started back at surgery now? But Satish, what's happening up in Scotland?
Yeah, we started operating from the 10th of June. We started off just by doing few lists a week. So we started off doing 4 per list, and then we have slowly ramped up. So I've done so far 3 lists. Yesterday we ramped up to, we increased my numbers to 5. So yeah.
Good. Can I ask, how many people do you have on the waiting list?
I don't know whether I'm allowed to say this, but I will. 1,600 as of
1,600.
Yeah. So
okay.
That's the backlog before. Still, the opticians
Yes.
just allowed to go back to work only 3 days ago, only to see emergencies. But once they're allowed to see routines, then I think the floodgates will open. So these are all pre-COVID, pre-lockdown numbers.
Okay. Beta, what's the situation in Romford?
So we are not allowed to operate in our own hospital, and we have to operate at another site. So we have got some space at not a local, but a nearby private hospital. The problem has been that a lot of our patients have been pre-assessed before to be ready for operation at Queen's. But now this private hospital requires these patients to be re-pre-assessed because they can't take patients with very high anesthetic lists since they just don't have the backup to be able to deal with these patients. So our patients are going to them to get re-pre-assessed, and then they're being rejected because they're too high a risk, or there's some anesthetic issue, or they just can't do that particular kind of surgery.
Okay. So Peter, how many patients do you have on your waiting list?
So our
What's backlog?
So our cataract pre-COVID waiting list was about 500-600 patients.
Yeah.
And then we've cancelled approximately 80 to 90 patients per week since the middle of March. So probably double that number in total across the specialty.
Okay. And what's the situation in Dublin, Michael?
I'm mainly now in private practice, but what happened about 3 months ago is that the state commandeered all the private hospitals, and so no surgery, no elective surgery took place in any private hospital. But now they have relinquished their hold on them, so we're now back able to function from the 1st of July. And so I'm back working again. I'm backing up, be doing routine surgeries from Monday onwards. So, but I've been able to do emergency work. So that's been the background to it. As regards what I've on my way, I do a lot of refractive pediatrics, but I have about 60 cataracts, about 80 to 100 patients waiting for refractive surgery, and probably about 30 children waiting for miscellaneous stuff like strabismus, CUAs, probings, that sort of thing.
Yeah. Okay. And Julie, what's the situation in Belfast?
So the similar Beata's experienced the Belfast Trust commandeered some of the private lists. So we actually only had about 2 weeks downturn and started operating on the 30th March that week. We made it really a plea that we've such long waiting that some patients were very visually impaired, and we did have an interesting experience because not all wanted to come, obviously. So it was a bit of work to get people in, but some equally were so keen to get in, you know, because their vision was so poor. So we've been going along, and we're back into operating on the NHS premises from last week.
And the size of the waiting list, the backlog?
Oh, you don't want to know. We have, so when you're asking for size of the waiting list, is this surgical or outpatient? Because I wasn't clear when others answered.
It's the surgical, it's the cataract waiting list.
Yes, so we have the surgical waiting list is 3,500. Now this is for 3/4 of Northern Ireland, and the outpatient people waiting to be seen is 10,000.
So there's an enormous backlog.
Enormous backlog. That's why I was trying to press for some ongoing surgery. Yeah.
So Julie, I mean, you were telling us earlier on that you've got a prioritization. Do you want to tell us how that works, and perhaps other people can tell us what they're doing? Because the problem is we have this enormous backlog, and the question is, who do you operate on, and how do you manage it?
So because of the enormous, backlog, our experience was that we were phoning 20 patients to get one in because of, they were shielding, they didn't have anyone at home, they didn't want to come. So we have developed this cataract prioritization list, which is based on the Eucharis A, B, and C categories. We have medical students in phoning all the patients, filling in the questionnaire, and I don't know if you want to, I'll show you very briefly.
Let's have a look at it.
On screen. Is that sharing now?
Yes, it is.
You see? Yeah. So, I mean, basically we go down sort of the graphics, first or second eye, DSE grade, which is our surgical grade, VA at listing, and they have to fulfill criteria A and B of the Eucharis criteria. And essentially, we ask them about their fitness, etc. And then we group into those, need surgery, medically fit, willing and able to attend, and so forth. So we are doing that. It is taking some time, but it is working, and it is helping our pre-assess nurses a lot. So they're not spending
and so
time.
this is I mean, so how long does it take to actually fill this form in?
About 20 minutes, and they do want to talk, of course, and that's why our trust has employed medical students 15 hours a week. So we've grabbed some of those to you know, it does take time.
Yeah.
On the waiting list, people can't be doing this. So, but hopefully we'll end up with a nice prioritized list of people.
So some,
to, you know,
here's Vinod. Hello, Vinod. Vinod, you're on mute, I think.
I hope you can hear me, David. Apologies again
we
for
can.
the
We
later
can.
on.
That's good. Okay. So, Vinod, nice to see you. Thank you for joining us. We're just talking. Have you started surgery in Cardiff?
Yes, we have. This week we've started routine surgery.
And how many patients? What's the backlog?
Backlog is somewhere in the region of 800 to 1,200 patients in the 2 units that I work in.
So there's several systems for prioritization. I mean, some of the systems you end up with a numerical score. You don't do that, Julie?
Yes, at the end, we do end up with a numerical score, and then we categorize them into these, yeah.
Are other people using the same, Beta, are using that sort of thing, or what's the...
No, so we're using the college complexity score, the P score. So each of the surgeons is going through their own PTL and assessing the patients and their need for surgery. Most of them are P3, so looking at the cataracts, they're patients who have a cataract, but it's not sight-threatening, there's no urgency to it. You occasionally get the P2 cataract because they've got narrow angles, so you want to get that cataract out.
Yeah.
But that's what we're doing. And then, of course, on top of that, there's the risk stratification score, which is the one that was developed by the college that we're also using. Talking to the patient about the risks of COVID, or what they've been doing, whether they want to have surgery.
Well, one of the problems is, do you actually consent the patients that there might be a risk of getting COVID by coming in to have the operation? Is that a thing that you have to discuss?
Yes, we do. We do have to discuss it with them. We have to say to them, there is a risk. The risk is very small, but it's not zero. Yeah. And we also say to them that even if they get COVID, the majority of patients do get a mild version of COVID.
Yeah. What's happening up in Scotland?
It's very similar to what Peter just said, David. We are informing patients either during the telephonic pre-op assessment. Initially when we started, there were some confusion within the trust. They wanted patients to be isolated for 2 weeks prior to coming in, but then we talked them out of it. So currently for cataract surgery, it's only 1 week of self-isolation with no COVID testing.
Yeah.
But as for other specialties, they have 2 weeks of isolation and COVID testing.
Right, because that's the next thing. There seems to be a lot of variation in what people are accepting as acceptable, and whether you actually swab people, whether you have to self-isolate people. What's actually happening around with that?
Well, currently, Scotland. Yeah. Sorry.
Bernard, to tell us what's happening in Cardiff. Do you have to
David,
swab?
we have 2 theatre areas. We have amber and green theatre areas. For our green theatre areas, in both of my localities, we are isolating the patients for 2 weeks and then testing them 72 hours prior so that the results are back in time for their planned surgery. And that's not because we feel it's necessary, but we feel it's necessary at the moment to give people confidence, to feel that we are doing all that there can be under the circumstances. And in addition to that, as Bita has pointed out, that we are still warning the patients about the risk of COVID. In the amber area, which is largely for vitreoretinal surgery, for example, or urgent suspected cancers, it may not be practical to isolate patients for 2 weeks. So we just get on with the surgery, and that area is treated as potentially infectious.
Right. Well, what about, are other people doing swabs, and what's the situation in Belfast? Do you swab your patients there?
Yeah, we're still on the swabbing 48 hours before and the 2 weeks isolation, and we've not been successful in talking the executive down to 1 week. It is causing a bit of a problem for the patients, because they've already been isolating a lot of them, and you know, an additional 2 weeks is quite a lot. So we're hopeful.
I think one of the things is there's quite a lot of controversy about doing the swabs because about 30% of patients are actually have a false negative, don't they?
Mm-hmm. That's right.
So it's, you know, you can be falsely reassured that they don't have it when they actually do have it.
And we have the birth situation where we don't swab any people getting anti-VEGF injections. I know in parts of the country they're being swabbed as well. So it seems to be one rule for one and not for the others.
Yeah.
I think, David, you make a good point, David, but it's important to remember that it's not the negative ones that we are doing the swabs for, it's the positive ones, because, you know, the false negatives, of course, does mean that having a negative test is less relevant.
In Dublin, very similar to Belfast, people are advised to self-isolate for 2 weeks. 2 days before the surgery, they have the swab test, and then the surgery is performed. But for patients, like I said, for injections, people with refractive surgery, these people don't have any tests done beforehand. So it's the only ones that are coming into the main operating room, into the main hospital, that are being scrutinized.
It's interesting. Are the regulations set by the hospital or by the Welsh office or the Irish?
In Ireland, they're set by this crowd known as NEFIT, which are a so-called expert group which advise the government, and they're made up of people from the health department and various agencies, and they are the people that drop the guidelines.
So it's in sort of national. Is it the same elsewhere?
So in Belfast,
yeah,
go ahead.
Julie.
So in Belfast, it's set by the government, but there is a clause that says if your college recommends less, then we can go for that for patients who are under local. And I know the gastroenterologists are down to a week because they have given that guidance. Their college has given that guidance.
I have to say, in Wales, it's not a national picture, I'm afraid. It's very much down to the localities.
David, we've actually got a comment from JP Donjou up in Newcastle, saying that they don't routinely swab at the RVI based on the NHSE, saying that day case and outpatient procedures don't need it. So he was actually interested in this specific point, see what everybody else is doing.
I think it's interesting. We had the webinar that we had 2 weeks ago with Rudy Noitz from Holland. They've actually stopped doing any swabs at all, I think, haven't they? Because they found that the incidence of getting a positive was actually pretty low, and the risks of being reassured by a false negative. So they've just given it up and are just taking patients in as they come.
I mean, I think we have to, we dress up and we treat all patients as if they're positive, irrespective of what their swab result was. But we have to take swabs 48 hours before surgery, and that has been dictated by the private hospital. It prides itself on having been a COVID-free zone, if such a thing exists, and they want to keep it that way. So they insist that all patients have a swab done 48 to 72 hours before their surgery.
So if we're swabbing patients, what about the theatre staff? Are you swabbing them?
And not in where I work. Everybody in the morning coming in has their temperature checked, and they wear masks and all the usual precautions, obviously distancing and hand washing and so on, but not otherwise.
Yeah. Satish?
No, we are not, none of the staff are getting tested, or neither are the patients, David. I think the view is that I think there's a lot of regional differences here. So I think we successfully argued that it's a day case procedure for at least cataract surgery. And I'm still confused of how you can self-isolate for 2 weeks and then come and have a swab test done in 72 hours. It's kind of, sorry, I'm not smart enough to understand that part, but so I think we have gone down the route that having a very minimalistic approach to this, and we just ask the patients to self-isolate for 1 week. Once again, it's a very loose statement that is difficult. There's a lot of difficulty in policing it or making sure patients do it, but we just say them for the sake of saying it, and we just get on with it.
Yeah. I think one of the problems is there's an awful lot of variation, isn't there, with regulations, and it's difficult to know from hospital to hospital, region to region. Well, what about in Cardiff?
Well, it's an aspiration to test staff, but it's not happening in practice.
Yeah.
And I think, as Satish says, that there are questionable kind of values to doing testing, if you like.
Yeah.
If you do test staff, how often should you test them? You know, the aspiration locally has been to test all staff twice weekly, but as I say, in practice, that is not happening, David.
Yeah, well, I mean, yes, it's one of the problems, of course, with self-isolation is who actually knows the patient's self-isolated. I mean, from talking to people, self-isolation means seeing the grandchildren, going down to the shopping and all that sort of thing, doesn't it? I mean, it's there's an awful lot of variation between what people actually do and what they say and what they do in terms of that.
Well, if you look at it, David, I mean, the whole, there's a lot of lack of scientific evidence. I mean, does it 1 meter, 2 meters, depending on where you live, what country you're in, masks or no masks, up to about a month or 6 weeks ago in Ireland, nobody recommended masks. Now they're compulsory on public transport. They're going to be compulsory in shopping centres. And so, you know, I think a lot of this stuff we've only learned as we've gone along, and there's a whole lot of experts who've grown up here anyway in this country. They appear every night on the television and different ones, and so I'm sure it's the same in other countries as well. Swabbing, as you say, 80% successful, 20% false negatives or false positives, I think. So I think there's a lot of this that maybe a lot of what we're doing, swabbing people before cataract surgery, maybe is a waste of time.
Yeah.
And a lot of the, as you say, self-isolation, nobody policing that. So a lot of this stuff is very much up in the air at the moment.
I think so. One of the things people tell me is that when they phone patients up to get them to come in, there's a reluctance of patients to come in. Are you finding that?
Yeah, up to recently that was the case. Older people were not prepared to come in for anything, and a lot of those people not in the eye, in ophthalmology, but in other areas haven't been coming in. So there are a whole lot of people, I'm sure, as they are in the UK, where they have been, their treatment is delayed and they have serious life-threatening conditions. And that's been one of the problems, I think, that we're now going to face. We're going to see more people with morbidity, mortality, more so than here in this country anymore, more than have died from COVID.
Yes. I mean, do you think that the reluctance to come in is getting better now as people are getting more used to the system opening up? I mean, Beta, what's happening in Romford?
So I think initially there was a reluctance, but then we only started operating last week. And as the 3-month embargo that was given by the government on certain groups of individuals is lifted, they're becoming more keen to come in to the hospital. It's interesting, just going back to that point about swabbing, was one of the rules that they've put in place is that patients should try to avoid coming on public transport, but that doesn't mean they can't come on public transport. So if you're self-isolating for 2 weeks and you're coming on public transport, what is the point of that self-isolation? It's just the rules in many ways just don't make sense. However, certainly all the patients that I phoned up are very keen. For some of them, it's been quite difficult, this process of self-isolating, because they need to have someone to bring them in. And if they're self-isolating, then they need to go and stay with that person who's going to be bringing them in. And so it's the logistics of what they do during the self-isolation to ensure that they can get into hospital that's been difficult for some of our patients.
Yes, yes.
The other comment, David, that we've got from Raj Govindan is saying that they're actually doing their testing 3 days before they come in for surgery. But then if they haven't got a result on the day, or they don't have a negative result, they're cancelling patients because they don't know.
It's full of inconsistencies, isn't it?
Yeah.
What I was going, if a patient decides they don't want to come in, what do? Do you leave them on the waiting list? Do you take them off the waiting list?
Well, it doesn't arise in my case because most of them will come in.
Yeah.
But in the public system, I don't think they'll get knocked off the waiting list and probably get back to the back of the line again and wait some years in Ireland, where like Belfast, like some of what you've been describing, where thousands on waiting lists. And they'd been like that before COVID. This COVID only made it a lot worse.
Yeah.
And in Ireland, what they do now, what they did before, what's known as the NTPF, National Treatment Purchase Fund, where they buy. I'm sure they do it the same in the UK. They buy treatment off the private hospitals. And the private hospitals, and I've worked in both of them for years, 30 years in the public, 34 in private. The private hospitals are, I always say, double the numbers in half the time with half the staff. And I'm sure it's the same elsewhere, but maybe not. Maybe Belfast in the UK is so much more efficient in the public system. But that's the reality I found when I worked in the public system.
Yeah, I doubt it. Can I ask you, are you still seeing new patients? There are some places that say that you shouldn't see new patients until you've worked off the backlog of the old ones. What are people doing about that?
Oh, I'm not, I see, of course I see new patients. They're pouring in on the last week.
Yeah, Satish?
Well, at least in Scotland, legally, we are not allowed not to see new patients. So once the opticians, almost over 95% of the referrals to hospitalized services comes through the optometrists.
Yeah.
And only as of this Monday, the optoms were allowed to go back to seeing only emergency patients. But from 15th of July, they're allowed to go back to seeing routine patients. And once that floodgates opens, I don't think we'll have any legal right to refuse to see patients.
What about everyone else?
Bottom of the list.
Yeah.
David, one of the things that has come out of this crisis is that we have categorized all our patients, whether they are for follow-up or new review. And we have prioritized them according to their clinical needs. And we will see them according to that prioritization, whether they are new or follow-up patients.
Yeah.
And we're allowed to do that. What's not happening at the moment is that we're not seeing the routine 6-monthly reviews, if you like, or the routine cases that have been newly referred.
Okay. So let's move on and talk about social distancing, because that's another sort of kind of worms, isn't it? I'm very confused whether it's 2 meters, whether it's 1 meter. I think it also varies very much according to how easy it is in your hospital to actually do social distancing, because not every hospital lends itself to do that easily.
David, before we move on to this, can we just pick up just a couple of extra questions with regards to
do please.
One of the questions, if you've got patients who are testing negative, does it alter the PPE that people are wearing when they're operating?
Okay, that's good. Let's go and ask everybody.
No, it doesn't alter anything.
It doesn't. Okay. In Dublin, it doesn't. In Scotland.
Well, we are not doing any COVID testing. So I tried operating with the FFP3 mask for the first 2 lists. I found it extremely uncomfortable. One, I feel very suffocated and difficult to breathe and getting a headache. Second thing, I'm not able to communicate to my staff. They're not able to hear it. Even though it echoes inside my ear, the staff can't be able to hear it, neither are the patients. So as of yesterday, I've stopped using FFP3 personally for me, but still the nursing staff want to wear FFP3. Obviously, all the patients are masked, and the mask comes off once the drape goes on. But that's my view on PPE.
Okay, Beta?
So yes, we're using FFP3 masks, especially for GA cases, not necessarily for the LA cases. And that's irrespective of whether the patient is positive or negative. I don't wear any eye protection. I find it incredibly difficult to operate on protection. Even with the FFP3 mask, as Satish says, I find it suffocating. And more importantly, as again, Satish alluded to, the nursing staff can't hear what you're saying. So you have to shout louder. And I often adjust the microscope eyepieces with my chin, and I end up dislodging FFP3 mask, which makes it even more difficult because then you have to try to put it back into place.
Okay.
So yeah.
Julie, are you treating everyone as positive, or
so,
making a differentiation?
Yeah, I don't think it makes a lot of difference. I had a survey today. Most are just wearing ordinary surgical mask. Interestingly, the VR surgeons who must have got used to the FFP3 masks are continuing to wear those, especially if they feel a bit vulnerable, if they have asthma, but generally just surgical masks.
Okay. And what's the situation as far as Cardiff is concerned?
it's very much left to the individual surgeons to decide
Yeah.
what level of PPE they're comfortable with. It's not mandatory to wear FFP3, but I did actually manage a whole list this week with FFP3 mask, and it was possible, but not eye protection, because I think in spite of the fact that I have passed the fit test, occasionally you do find that the microscope eyepieces tend to steam up, so there must be some leakage.
Okay, Sarge, so there's a variation there.
Yeah.
We seem to have a lot of variation about everything this evening. Any other questions?
Absolutely. Another question, somebody asked whether, well, Charles Diper has asked how people are coping for anaesthetic cover or procedures. And I think, Beta, you alluded to that earlier on, didn't you?
I don't quite follow what you mean by anaesthetic cover. So whether it's GA or LA, we have to wear an FFP3 mask for general anaesthetics. It's just, I mean, the whole process around the general anaesthetic is quite draining, because the anaesthetist and everyone is in theatre, and if you happen to be outside, you're not allowed to go into the theatre until the patient has been induced for 5 minutes to let the aerosol settle. Then once the anesthetic, the general anesthetic is over, the patient has to be extubated, and you have to wait another 5 minutes before you can leave the theatre. And last week I thought I would just try to sneak out earlier, and I was told off, and they have a little timer that's actually counting down 5 minutes. So you can't even sort of pretend 5 minutes has gone. But it just makes the whole process so much more protracted.
Yeah.
And it's quite interesting, just coming back to this issue of the FFP3 and what kind of masks. One of my colleagues failed the fit test, and she's been given this almost space helmet to wear with a tube coming around, down the back, which makes her look as if she's someone from one of the spacemen in Alien, with a little visor in front. And I have no idea how she's going to manage operating wearing all that. So,
Can I ask, have you changed your surgery in any way, your surgical technique? I mean, topical, are patients giving migraine, preoperative, are they dilating their pupils at home before they come in? Are people there are some surgeons who are gowning the microscope because of aerosols. What are we doing? Any change in surgical technique in Cardiff?
Not so much surgical technique, David, as prepping the patients. So we are seeing the patients prior to isolation and doing all the necessary paperwork so that on the day of surgery, they arrive in a staggered fashion. So we don't have the traditional, everybody comes in the morning prior to the list and we do a morning ward round, as it were, pre-operatively. So that's gone. When the patients come in, they are given a mask. As I say, they come in staggered. In the waiting room, they practice social distancing. Once they're in the theatre,
does that actually work? Getting people, I mean, can people get there at a certain time for an operation? I mean, as far as London, where the traffic is unreliable, you know, public transport is pretty poor. Yeah. Very difficult, I would imagine, to get people to come in a staggered way to actually run a list.
It's not been a problem. It's not been a problem, David. And generally, our experience has been in the past that patients tend to arrive early.
Yeah.
Really too early, if you like.
Yeah.
And one of the things that we're doing now is to kind of gatekeep and ask them to wait in the car if they have arrived too early, to say that, you know, we'll call you when your time comes, as it were, just to avoid overcrowding in the waiting areas.
Julie, what are you doing? Any change in your surgical technique?
Not really, not draping the microscope, not really limiting the number of staff, no, nothing really. We've reduced the number on the list and we try to minimize time there, but we're starting to increase again as we get a bit slicker in the flow.
Michael, any change in your surgical?
No, not the same as Julie. I don't drape the microscope. The numbers on the list are going to be reduced. I think that's the one factor that's emerged. Try and avoid general, although some people will need it, kids in particular. General anesthesia, as has been outlined, is a bit of a pain because it's a huge delaying issue in terms of getting through cases. But other than that, social distancing, obviously people are separated and kept separate, and the usual stuff, masks and so on. But other than that, nothing else.
And in air?
No difference to the surgical technique, David. For the first couple of lists, I saw these patients a week before, and we gave them pre-op dilating drops to be used at home.
Yeah.
So that as soon as they walked in, we could straight take them into the operating theater. And we had one dedicated nurse per patient so that the amount of physical contact was minimized. We did that for the first couple of lists, so that seems to work well. But I think we're slowly moving away, and then we'll just go on to a routine way of doing things where we see the patients and we dilate them on the day. But definitely our numbers are much reduced. First couple of lists, I did 4. Yesterday I did 5. But we are hoping that we'll slowly ramp it up.
Yeah. Okay, Beta, surgery?
So no changes in surgery. The advantage to working in a private hospital is that there are many individual rooms, so all the patients can come in at the same time and go into their own room where they have one dedicated nurse taking care of them. The hospital doesn't use mid-research, so you have to go back to writing preoperative drops up and ensuring that they're put in an adequate frequency beforehand. But no change to surgical technique. And in terms of staffing, any staff that's failed their fit test can't come in for a general anesthetic case. So sometimes you are limited who can be your assistant depending on your case.
A number of hospitals don't allow patients to bring in any relatives or anyone to accompany them. The patient has to come on their own. Is that, have people had that problem? And because a lot of our patients are elderly and they actually need a bit of help, don't they? How are we coping with that?
Their relative is asked to wait in the car park.
Yeah. Cardiff, people in the car park anyway.
Very much the same, David.
Yeah, okay. And everyone else are doing the same thing, no companions?
No companions up in Scotland, David, but the Scottish Executive have put shielding policy for over 70s for elective surgery till the 31st of July. So we are not allowed to bring patients who are over 70. So we are literally, there is no waiting list at the moment. We are just cherry picking. All the patients we have done so far are below 70.
Well, because the average age for cataract surgery is 76, so it actually cuts your waiting list down.
Exactly. So we had to go through the list to see, there's a 69, let's pick that. So that's what we're doing now.
I haven't seen those guidelines, but they've been official guidelines. They've got to wait in the car until they get a phone call. They shouldn't be accompanied by anybody. But in practice, certainly I can't. A lot of the elderly people have to be accompanied by somebody. They can't come in on their own.
Yeah.
And they need somebody to, and this idea that you shouldn't speak to them before the surgery, I think that again is not credible, because you've got to talk to them, tell them what you're going to do with them, because some of them might have been on the waiting list a bit longer, and you've got to talk to them afterwards and tell them how it's gone. I think people need reassurance afterwards. So these guidelines, some of them in my view, are drawn up by people who don't do any surgery, who've never been in the operating room. Because in my view anyway, these guidelines are not credible.
So how many patients are we doing on a list now? What's the number in Belfast, Julie? How many do you do on the routine list?
Yeah, it's been in the private hospital. It was 5, and now we started 4 on the NHS list, and we're starting to train these operating again. But hopefully it'll move to 5 next week.
Mm-hmm. And in air?
For the first couple, we did 4. Yesterday I did 5. I didn't see any issues, so I think pretty quickly we'll be wrapping up to 6 or 7 per list.
Yeah. And in Romford?
So we are doing between 3 to 4, but that's how many we put on the list, and then we're at the hands of the pre-assessment of the private hospital as to how many of those are fit for surgery at the private hospital.
Yes. Okay. And in Wales?
Yeah, 3 to 4 cases per list, David, at the moment.
So you're actually doing what most of you are doing, a fraction of what you normally do then?
50%.
Yeah. Yeah. Do you think that's going to change? I mean, are we going to see that?
Yeah, we're already talking locally about increasing the numbers. There are some challenges, and those are really the logistics of particularly getting testing done, for example.
Yeah, it gets back to this sort of testing, doesn't it, really? And I mean, if somebody's tested, I mean, getting the results of the test back in 48 hours is quite a challenge, isn't it?
Yeah. it's not been an issue for us as yet.
It hasn't. Anyone else having issues with getting testing, with those people who are doing testing? Is it a challenge to get the results back?
No, I think it's got quite efficient. But I saw something in the UK where you can have a test done and have it back in about 72 minutes or so. Isn't it a new test? It's a nasal test.
I think there's a number of new sort of rapid tests, aren't there? But I think they haven't been actually sort of validated yet, really. So
this one was said to be validated by whatever group in the UK that validates these tests, and you could do it yourself at home. You could buy the kit. But I haven't seen it. It was on the London Times about 2 weeks ago, but I haven't seen anything further on it in recent times.
Do we have any problems with getting access to the right PPE? Is that, I mean, that was an issue initially. Has that been solved now?
Well, we haven't had any issue, but I know that we are going to start having issues with the FP3 masks.
Yeah.
And I know that for other specialties as well.
Yeah,
and then,
David,
yeah.
Sorry, I was going to say, even from the some of the comments coming through, obviously there's variability in terms of what PPE people are being recommended or asked to use in different units as well.
So let's go around and ask people. So if you see a patient for a consultation, what do you have? Gloves, gown, masks? What's happening? Julie, if you see a consultation, what's the routine PPE in Belfast?
Okay, so that'd be amber guidance for us, and it's mask, apron and gloves. The apron and the mask can do for the session, but you have to change your gloves for each patient. Not allowed to have the mask hanging, obviously.
And that's a surgical mask or FP2 or FP3?
Surgical mask, unless the patient is known to be positive, then that's
okay.
the whole thing.
I'm assuming it's for the outpatients, is it, David?
Yeah, yes,
outpatients, FFP2, both for the patients as well as for the surgeon. No gloves or no aprons for either of us.
Right. In Romford?
So as a patient comes in to have an outpatient assessment, they're asked a series of questions at the entrance as to whether they felt ill, whether they've had a temperature, so they pass that screening test. Obviously, when you're sitting behind the slit lamp, the 1 meter rule doesn't really apply in any way. I just wear we have a very large breadth screen, but I have to admit that I sometimes take it off because I just can't reach around it. When you use the lens to look at the back of the eye, I use a fluid resistant surgical mask. I wash my hands between every patient in front of the patient so they can see that I've washed my hands. And we clean the slit lamp with alcohol wipes between each patient. And that's it, really. The patient is obviously also wearing a mask as is required in hospitals.
And are you wearing an apron or a gown? No.
Well, surgical scrubs. Everybody wears, all the doctors wear
surgical scrubs. Yeah, okay.
We used to, when we're at Queen's, because it's such a COVID hot area, we wear surgical scrubs, although that's changing again. But at the private hospital, we're back to normal civilian clothing.
Okay. Cardiff?
So we're advised to wear a plastic apron, gloves, and surgical mask, but it's not policed.
Okay. And Ireland, Dublin?
Again, very similar to what Peter, patients are screened on the way in, temperature, asked a number of questions, had they been abroad, all these sort of things, had been in contact with anybody with COVID. And then I wear surgical mask, and as I say, I show them that I'm washing my hands, clean down the microscope. Nothing else.
Are you wearing an apron, a plastic apron?
No, not at all.
No. So the consensus is that people are mainly wearing surgical masks, I think, aren't they?
Yeah.
Apart from the Belfast, where you have FP2s, FP3s.
No, we don't.
No.
It was Scotland had the FP2.
FP2. Fluid resistant masks, both for the patients as well as for the doctors in the clinic setting.
Okay. Okay. So, talking about surgery going on, yes, another question.
I was going to say, should we take an opportunity just to catch up on a couple of questions?
Yes, do please.
Seeing as a couple of people have mentioned the private hospitals, we've had a couple of questions about, for those that it's relevant to, who has restarted private cataract surgery, but also who has restarted laser refractive surgery?
Okay, let's go around. So, Michael, you're in private practice anyway.
I'm going to start cataract surgery on Tuesday, and I'm going to start refractive surgery on Tuesday as well. So next week it's full on.
Okay, and did you find patients are coming in, they want surgery? I mean,
well, that's why I have about 100 eyes waiting for refractive surgery. They're championing at the bit, wanting to go. These are young people. It's a good time for them. They've spared a lot of money being on the lockdown, so they seem to be able to afford it, and they're waiting to go. So we're having to up the numbers each time and trying to get treat this list or get through it in the next month or 6 weeks with 100 eyes probably.
Okay, busy. So, Beta?
So I don't, at the moment, do any private practice. So,
yeah, it doesn't apply then. Vinod, are you doing any private work?
The answer is no and no currently, but I expect that will change in the next 4 weeks.
And in Belfast, Julie?
Yeah, so I don't do it myself, but I understand from the private hospitals that they are just so busy. The demand is huge.
Is that right?
They've started up, yeah.
Okay. And in Air?
I started private surgery last week as well, David.
And is there a big demand for it?
These are all, well, I don't know. These are all patients who were pre-COVID lockdown cancelled patients who are coming in now.
Yeah.
But like the CQC, we had to go through the Healthcare Improvement Scotland's directive to make sure that we have passed through all the necessary risk assessments before we could start doing. So we went through that battle of paperwork for the last 4 or 5 weeks. So as of last week, we were allowed to start private work. I'm assuming once the opticians are allowed to see routine patients, then the trajectory might be there might be an increased demand.
Okay, Sarge, any more questions there?
The next question that has come up a few times, have you guys been back long enough to comment on how it's impacting training lists?
Training, okay. Let's go to the president-elect. What's are you teaching?
As of last week, we have allowed the trainees to observe. We haven't allowed them to operate, but there are only 3 operating lists old since we started operating. But I don't see any reason why we can't get our senior trainees start doing at least one or 2 cases.
So that's slowly starting. Julie, what's happening in Belfast with training?
Yeah, so although the consultants are operating in the private sector with the NHS patients, the trainees were not allowed because of indemnity, so they haven't been operating. We've been doing a lot of cataract surgical simulation and have appointed an extra lead, and hopefully from next week they'll get a little bit of surgery, but it will be slow.
Starting slowly. Vinod?
I think it depends on the level of the trainee, David.
Yeah.
At the moment, we are kind of on the senior trainees, and the registrar that I have with me is a fairly competent cataract surgeon, so I don't see any reason why he won't be operating in the next fortnight.
Okay. Beta?
So our trainees were redeployed to ITU, and we've only got them back in the last 2-3 weeks. We have allocated them to lists. I don't think they've actually touched a patient yet. They're more observing, since we ourselves only started last week. So
I think the consensus there is that it's sort of slowly getting underway again, isn't it? But it's taking its time to get trainees back and get them into practice. It's a big problem. Sarge, next question.
Next question. So just going back to theatre, actually. Interesting question. So question about whether there's a difference in how people are prepping patients with iodine while they've got patient mask on. And in particular, the interest is because we're obviously getting an encouragement with regards to doing immediate sequential surgeries, and whether that's altering the way that people are looking at.
That was the next thing I was going to ask. There's been a lot of interest in immediate sequential bilateral surgery. Are people going to be doing? What's the attitude of people to that? Beta, you actually do it anyway, don't you?
We do. So our hospital is already set up for doing ISBCS. We've been doing it for the last 9 years. Our numbers were reduced because of commissioning and payment for the second eye, but COVID has really been a good catalyst for us to go back to the commissioners and get some payment for the second eye. We are offering it to everybody. I mean, there was the college seminar recently.
Yeah.
You know, it's not suitable for everybody, and Evie Mensa put a very convincing case forward. But for those people who it is suitable, we are offering them the choice.
Well, what's the percentage of patients that are suitable in your unit?
So the percentage in whom it's medically indicated is probably between 5 to 10%. Previously, when we did an audit prior to COVID, just when patients were given the choice of having both eyes done, the uptake was around 30 to 40%. And I think it'll be the same because patients like the idea of coming in once, getting both eyes done and going home. And the problem sorted, so that there's that less exposure to the hospital environment and all the risks therein.
So you think that there's going to be an increasing demand for it?
I think there's going to be an increase in demand because it's going to be increasingly offered.
Okay.
I think people are more aware that they can do it, and the uptake is going to be greater.
Okay. What about air?
I've never done it, but certainly it has piqued my interest. I'm really open to the idea.
Okay. And in Ireland, in Belfast, Julie, are you doing bilateral?
No, almost unheard of unless it's medically indicated. The reason for that is not that we've anything against it, it's just capacity. I feel it's just not right to be offering bilateral surgery when you have so many people waiting to get one eye done. So just when we have these big waiting lists, we can't offer that.
It's a logistical problem. What about in Wales?
I'm in agreement with Julie's view that personally I feel that where you have such a backlog, it just doesn't make sense, particularly in a healthcare system like Wales, where we don't have payment by result. So we are very much in this sort of old ways in terms of having a budget to manage our patients. So it's not likely that we're going to be increasing the numbers of surgeries that we do in the current climate. And in that scenario, to disadvantage some patients and to be offering bilateral surgery doesn't make sense to me.
Okay.
But where indicated, of course, it will have an increasing role because there's no doubt that it will lead to efficient ways of working in the current climate.
Yeah, yes. And Michael, are you using it in Dublin?
No, unless, as Julie says, it's an exceptional case, but it's medically indicated. No, all intraocular procedures we only do one eye. Obviously, in refractive surgery, I do both eyes at the same sitting.
Yeah.
But the biggest, I don't know what happens here, but we're a very litigious country here. And I think if you got a problem with the second eye, I got a bilateral endophthalmitis, I think you wouldn't have a leg to stand on.
It's interesting. There was the college seminar on this a couple of weeks ago, and I spoke to Steve Arsenoff, who's the Canadian surgeon, who is a big pioneer of it. He does 90% of his cases with immediate sequential surgery. So it just shows you if you can actually push things to a limit. So we're moving on. What about post-op follow-ups these days? I mean, people had surgery. Do people come in for a follow-up visit? Do you send them off to an optometrist? What do people? Has that changed to sort of to speed things up? What are you doing in Cardiff with your post-ops?
So, discharge after surgery to primary care was the practice that was already pre-existing COVID, and I think it will be more acceptable. I think now that even the surgeons who are keen to bring their patients back, I suspect, will be discharging them to primary care for routine post-operative care. Of course, there will be a cohort of patients who need to be brought back, and we will continue to see them.
Yes, yes, of course. But I mean, for the routine case, does anyone phone them the next day to see if they're all right?
We have not resorted to that.
Of them. I see within
So, Mike?
I see all these cataracts within the first week.
Yeah.
And in private practice, I think it's important. They expect that if they're paying you money, they expect you to see them.
I think it's a bit different in private practice, but in the NHS, I think a lot of people are discharging them with telephone follow-up. Peter, what happens in Romford?
So I make a point of going and seeing all the patients afterwards just to reassure them. And then they are discharged to the community. We're very lucky in our area to have a company called Evolutio that is doing a lot of the work for us in the community. They're triaging all the patients that are sent to our casualty. They are seeing our post-operative patients. We've diverted a lot of our glaucoma to the community. So they're seeing these patients routinely at 4 weeks. These patients are just not coming back to us.
Okay.
The issue does arise, however, that what happens if the patient then says, I want second eye surgery? Because previously they used to be seen in the hospital at the 4-week visit. You would then make a decision about the second eyes. We just don't have the setup where the opticians are able to assess and list directly for second eye surgery. So I think this is a flood of patients down the line who will be then referred back.
Back in they have to be referred back in again.
Yes.
There must be a way around that. What happens up in Scotland?
Well, in Ayrshire, at least our practice hasn't changed pre and post COVID. Patients have a direct number to call the day surgery unit ophthalmic nurse if there is a problem, but our nurses don't call them to check. We don't see them at day 1 or week 1. At 4 weeks, they go to the local community optometrists for their check. That's always been our practice, and we've just continued with that post-COVID.
Okay. Julie?
Yeah, so it's been interesting, and I think if there's one good thing there's come to this, we were seeing all our post patients, and it was really with a bit of a struggle that we're trying to change to community review. Some consultants were happy, others weren't, but now we're doing predominantly telephone reviews. So I think coming out of this, it will really facilitate the move community review. We have struggled with the boarding the second eye, and I think university consultants have said they will not accept boarding from a community optometrist. So we decided that the plan would be made when the patient was first seen, and all was well, they would be listed when they were leaving the theatre. You know, if all is well, they needed both eyes done, the listing would be done at that point. So, and if there was a problem, they'd be coming back anyway to the hospital.
One of the problems that concerns me about the community follow-up is audit. I mean, how do you know what the refractive outcome is and that sort of thing?
So that's going to come back to us with Medisoft. So we're going to have Medisoft community portal.
And that will come back to you then?
They will come back. And so we weren't going down that road until we had that. Could have changed that a little, but we're still on course for that.
It's important, isn't it? Yes.
Yeah, yeah.
Satish, you've got your hand up.
We have a system where at 4 weeks, when the optician sees the patients, there is a form they have to fill in with their unaided vision and the manifest refraction and the refraction details, and that gets sent back to the hospital. So that's how we complete our audit look, David.
So how you do it? Okay, good. Sarge, any other questions that are coming through that you want to bring up?
Just a very yes or no question. Obviously, again, we were talking about PPE earlier on. Somebody's asking how many of you are actually wearing eye protection for surgery?
Okay, let's go around. Michael?
No, I'm not wearing any eye protection.
Beta?
Absolutely not.
No. Vinod?
No.
No. Julie, you wear spectacles
no,
anyway?
No, from Belfast. They've all tried it, can't do it.
Yeah. And Satish?
No, I haven't even tried it, but definitely no.
Yeah, I think it's impossible, isn't it? I mean, to wear a visor and to operate is really, really difficult. So we're going to the end. I can see Philip there looking to summarize. Just one of the things, a final question for you. I mean, people say that after COVID, things are never going to be the same again. Is there any one thing that you think that you're going to keep out of this? If someone said to you, what's the one thing that is worth sort of really keeping? Well, let's just go around and ask everybody what they think is, you know, is there any benefit? So, Satish, let's start with you.
I think it has really opened the door for teleconsulting, David. And there's better ways of seeing these patients, more of community shared care, and also teleconsulting, and all these patients don't have to be seen in the hospital setting. I think it's definitely going to open the ways more for shared care with primary
okay.
community and teleconsulting with the hospital setting as well.
Okay, Julie,
Yes,
what would you take home?
Definitely telephone consultations. We're still struggling a little with the video consultations because some platforms are more difficult, but certain types of patients, not necessarily cataract patients, are very, the telephone reviews are very good. And I'm thinking of like the inherited retinal degeneration patients. I mean, really excellent, where they don't change very often. So telephone reviews.
Okay, Vinod?
I think it will give us the opportunity to use technology, and hopefully technology that not just is out there, but can be put into practice, because this will accelerate. So it's
okay, Beta?
So I think in order to be able to practice telemedicine safely, we need electronic patient records. And that's something that we're really pushing for at the moment.
Yeah.
Because in order to do it thoroughly, properly, and to document everything, you need access to the patient records. And if you're off-site, the best way of doing that is electronically, as well as electronically with your community providers. So we're really pushing for that, and I'm hoping that's the really good thing that's going to come out
of it. Okay, right. Michael, what would you take home?
I would take home, I think we should continue to use masks, which I think are a vital part of it all. And I think it's reinforced the importance of hand washing.
Yeah, okay. So a mix, but there's obviously a big interest in video teleconsulting, which we're going to have to rely on the technology for. That's going to be developed, isn't it? Look, I think we're getting on for 7 o'clock, so I think I'd like to thank you all very much for joining us this evening. It's been extremely interesting to know. There's obviously a big diversity of practice with what's going on, and very interesting to see the problems that people get and how you're actually coping with it all. It certainly isn't easy. I'm just going to invite Phil to say, Phil's the president of Eucharist, just to sum up for us, Phil. But Phil, we're not going to let you get off sort of scot-free. What are you going to take home? What's the one thing from COVID that you think is going to be helpful?
The patient pathway. I think smoother transition of patients through the perioperative journey, post-operative use of non-medical personnel, non-hospital settings, EPRs, and we're going to get leaner. We've been made to be leaner, whether we like it or not, and I think we will ultimately all, as I've said previously, find something positive in the whole COVID debacle, and actually good will come of this eventually.
Good. Okay. Well, thank you very much, Phil. So hand over to you. And
thank you. I'd like to just add my thanks to you, David, for very skillful chairing, and to all the panelists. You, like others, including David Abrat and Paul Ursel, are fond of calling our august organisation UKIS. Just to remind everyone, it used to be called UKIS, the United Kingdom Intraocular Implant Society, but for many years it's been called UKISCRIS, which of course is UK and Ireland Society of Cataract and Refractive Surgeons. And I've always felt that some of the meetings that work best are the ones that involve our westerly neighbours, and I'm not talking about Vinod here, I'm talking about the Irish contingent. So I think that's been a really fascinating roundup. What's interesting is that how many things are happening the same, but actually there's a lot of local flavour, a lot of local nuance to how services are being provided. So thanks to all of you, I've really enjoyed it. Thanks to Daybreak Medical, our sponsors. That's been fantastic to have you involved. And I'd like to thank everyone, including the 115 participants still on, for their attendance, and to encourage you all to register for forthcoming meetings. 2 weeks today, our own Mayank Nanavati will be chairing a session on what would you do next, some anterior segment case presentations. So coming back, really, although this I'm sure will have a COVID flavour as ever, it will be going back to the more clinical aspects, our normal métier if you like. And so as time goes on, as we hopefully recover from COVID, there'll be increasing content of traditional clinical fare in these webinars. And the auspicious presenters there will include Alan Barsan, Paul Ursel, Jonathan Ross and Sanjay Mantri, all of whom are linked in one way or another to Eukiscris. 2 weeks after that will be another webinar, this time featuring some of our the YOP members, the youth members, who are getting a fantastic panel together on AI use to optimize cataract surgery. And again, the program for that will be circulated shortly. And the meetings will continue. Please keep an eye on our ever-changing website for news and views. And of course, we continue to revise the guidance, often in combination with the Royal College. Within the next day or two, the joint Eukiscris and Royal College advice guidance on immediate sequential bilateral cataract surgery will be coming out, and I'd encourage you all of those to look at that and learn and hopefully participate. So, thank you all for your attendance. I look forward to seeing you again in 2 weeks' time.
Thank you very much.
Thank you, everybody. Thank you, Philip. Thank you, David. And the evaluation form will be sent directly at the end of the webinar. Good night.
Thank you. Good night.
Good night.
Thanks. Bye.
Right.